Welcome. We're so glad you're here with us for today's Harper Lecture. The Harper Lecture series began in 1979 with Hannah Holborn Gray speaking in San Francisco. As the need for critical thought remains apparent in all areas of life, we proudly continue this signature program to bring you stimulating conversations and fresh ideas. Our UChicago community is a global one, and we are thrilled that technology can help us stay connected to one another. As you enjoy today's lecture, please note the following items. Your camera and video will be off. However, we encourage you to ask questions. Please use the Q&A box at the bottom of your screen to ask a question at any time during the talk. Closed captions are available by clicking the box at the bottom of your screen. Click Show Subtitles to enable this feature. If you're having trouble with audio or video, please try shutting down programs in the background, or you can dial in from your phone. Thank you once more for joining us. We couldn't do this without you. Hello, everyone. Welcome to today's Harper Lecture, Changing the Future of Cancer Health Disparities, with Dr. Kunle Odunsi. I'm Andrea Hodgman, Interim Director of Alumni Engagement and the Program Manager for the Harper Lecture Series. On behalf of everyone at the UChicago Alumni Office, thank you for joining us. Please allow me to introduce our moderator. Dr. Blase is a professor of medicine at the University of Chicago, the Deputy Section Chief for Strategy and Network Development, Executive Medical Director for Cancer Accountable Care, and a GI oncologist specializing in the treatment of patients with colorectal, anal, pancreatic, and neuroendocrine cancers. He is an associate editor of the Journal of Oncology Practice and has received awards recognizing his critical and teaching efforts, and was recently chosen as a Bucksbaum Institute Senior Faculty Scholar. He is actively involved at the federal and local level in developing alternative payment models for cancer care. He has authored more than 100 peer-reviewed publications. He is currently the COPI of a 5-year NCI Moonshot Grant, accelerating colorectal cancer screening and follow-up through implementation science in Chicago, aimed at improving colorectal screening among federally qualified health centers in Chicago and Northwest Indiana. Dr. Odunsi, thank you for joining us. Dr. Polite, I'll hand things over to you.
Wonderful. Thank you so much, Andrea, for that introduction. I am honored to be here today. I don't just play an alumnus. I actually am one of the University of Chicago, having received undergraduate and graduate degrees in 91 and 92, and received my degrees from Professor Gray. Certainly had the honor of doing that. So I think I've spent about 27 of my years on Earth here at the University of Chicago. So the Harper Lecture Series and our alumni in the school obviously is near and dear to my heart. I have the absolute pleasure to introduce today Professor Kunle Odunsi. He's the director of the University of Chicago Medicine Comprehensive Cancer Center. He is the Dean for Oncology in the Biological Science Division and the AbbVie Foundation Distinguished Service Professor of Obstetrics and Gynecology at the University of Chicago. He's done tremendous and groundbreaking research in the areas of tumor immunology and immunotherapy, focusing on the mechanisms of immunorecognition in human ovarian cancer and preclinical as well as clinical development of tumor antigen targeted therapies. He is the co-principal investigator of the Roswell Park, University of Chicago Specialized Program of Research Excellence, known as a SPORE, one of the most competitive and highly sought after cancer grants in the country, with a SPORE focused in the area of ovarian cancer. As the director of the Comprehensive Cancer Center, Dr. Odunsi oversees all programmatic aspects of cancer at the University of Chicago, including our tripartite mission of research, patient care, and education of the next generation of scientists and clinicians. He sets the center's strategic direction, which emphasizes basic, translational, and clinical research, collaborative cancer discovery and care, outreach and engagement of the center's catchment area, and expansion and development of opportunities for early career and promising cancer researchers. Dr. Odunsi continues to treat patients and mentor physicians in the clinic. On a personal note, I've had the pleasure to work with Dr. Odunsi on our initiatives to maximize accrual of patients throughout our growing cancer network and our efforts here in Hyde Park to modernize our clinical trial infrastructure, which will continue to enable us to bring the next generation of treatments to our cancer patients today. He understands that the University of Chicago serves a unique role among the NCI comprehensive cancer centers in the diverse population that we serve and our obligation to bring the highest level of cancer care and research to all of our patients. And we also have an obligation to serve as a role model for other cancer centers around the country on the importance of keeping cancer health equity at the forefront of all that we do. His insight, professionalism, and attention to detail is already paying dividend in the short time he has been with us in our clinical trial operations, and I am honored to call him my boss and my colleague. Dr. Odunsi, please, we're a pleasure to have you. It's just an honor to have you here. The floor is yours.
Okay, thank you for the kind introduction, Blase. I'm just going to share my screen. So first, let me thank the organizers of the Harper lecture for inviting me to speak on this most important issue of our time, which is the subject of cancer health disparities. I would also like to thank all of the attendees for taking time to listen to this presentation because I know everyone is busy at this time of the year. So the objectives of my presentation this evening is really to try and describe the magnitude of the problem. How big is the question of cancer health disparities? What are the contributing factors? What are we doing about it? What are we going to do about it as a comprehensive cancer center, UChicago Comprehensive Cancer Center? How will the new UChicago Cancer Hospital help? And how can we reimagine the future state in terms of trying to address cancer health disparities? So let's start by definition. What is health disparity? What does it mean? It's simply when you have systematic health differences that could be related to two things. Number one, group membership, whether you are part of a socioeconomic group, gender or ethnic group, and that is affecting differences in health outcome. The second category is when you have systematic differences because of access to resources. Resources such as knowledge, health literacy, for example, and practices, behaviors that are avoidable or that are primarily socially determined. So we know that remarkable progress has been made in the outcome of cancer patients in the United States over the past 50 years, especially since the establishment of the National Cancer Institute and the signing of the National Cancer Act more than 50 years ago. But today, about 1 in 3 Americans will still be affected by cancer. But the problem is it does not affect all people equally, and population groups that may experience disparities could be defined based on race and ethnicity, disability, gender, sexual orientation, geographic location, income, and all of these other things that are listed on this slide. So let's go over some fast facts, some key facts to be able to frame the discussion, to be able to put this in context. So if you think about death rates in all cancer types, Blacks or African Americans have higher rates than all other ethnic groups, racial groups, for many cancer types, but not all of them. Think about breast cancer, for example. Similar rates of breast cancers, but Black women are more likely than white women to die of breast cancer. If you look at rates of colorectal, lung, and cervical cancers, they are much higher in some of the rural areas, rural populations in the United States. prostate cancers. Black men are twice as likely as white men to die of prostate cancer, and they continue to have very high rates of death among all US populations. So these are some key fast facts that we need to keep in mind. And there are additional facts that I would like to share. The role of education. The less educated are more likely to die prematurely from colorectal cancer. Hispanics and Black women, higher rates of cancer of the cervix and higher likelihood of dying from cancer of the cervix. American Indians, Alaska Natives, higher rates of liver and bile duct cancers. The rates of high-risk behaviors such as smoking, alcohol, are higher among lesbian, gay, and bisexual youths than among heterosexual youths, and all of these can predispose to higher rates of cancer. So we can see that there are, in fact, disparate outcomes, whether you think about the incidence or the mortality, the risk of dying from these cancers. They are different based on all of these different, whether you are white or Black or Hispanic, they are different. Let's drill down a little bit more on breast cancer, for example. If you look at this, this figure here, look at the blue line that tracks the rate of death from breast cancer in the United States across time, starting from about 2010 till 2019. Look at the mortality rate of death in Black women along the blue line compared with all of the other populations. You can see there's a striking difference where Black women are more likely to die compared with all of the other groups of women. And we see the same for prostate. Prostate cancers in Black men, again, the blue line. You can see the gap between the blue line and all of the other lines, whereby, again, Black men are more likely to die from prostate cancer compared with other populations. So what's going on here? Why is this the case? What are the contributing factors? Over the years, for many years, the explanation for this has been, well, different groups have different biology, or they have different types of genetics, or they have different behavior patterns that may explain these outcomes. But many studies have shown that biology, genetics, behavior, which are critical, they are important, they are contributors, but they do not fully explain the disparities that we see across different racial groups, different socioeconomic groups, and all of the other groups that we talked about. So what are the other contributing factors? So we really need to look under the hood of this car, okay? If the car has an issue, you need to, get under the hood and try and fix it. So when you begin to do this with regards to cancer healthcare disparities, you come up with a number of factors that have been called social determinants of health. This relates to poverty, structural racism and discrimination. And for years, these actually have been very difficult to define very clearly, and they are difficult to tackle, difficult to address. But why are we suddenly talking about it today? Or why has it become a significant topic of interest? It's really because all of these issues were amplified by the COVID-19 pandemic. But today we're going to focus on cancer, not on COVID. But it really highlighted that as a society, these issues need to be addressed once and for all. So what do we mean by social determinants of health? And I'm going to state here that this issue of this recognition about social determinants of health, again, is not new. Look at these statements from the Committee on Social Determinants of Health. This was a federal commission in 2008. This is more than 10 years old. And this showed that the poor health of the poor, the social gradient in health within countries, the health inequities between countries are caused by unequal distribution of power, income, goods, and services globally and nationally, unfairness in the immediate visible circumstances of people's lives, access to healthcare, school, education, conditions of work, their homes, their communities. All of this affect their chances of leading a flourishing life. And here's another statement from this commission, that unequal distribution of health damaging experiences is not a natural phenomenon. It is a result of a toxic combination of poor social policies and programs, unfair economic arrangements, and bad politics. And together, all of these structural determinants and conditions of daily life lead to the social determinants of health and are responsible for the majority of the health inequities that we see between countries and within countries. So let's drill down a little bit more. What exactly are the components? So here is a figure that I took from the NIH website that really drills down these 5 components. That when somebody is sick, when somebody is struck by cancer, when cancer strikes, there are all of these social determinants of health at play that then interact with genetics, that interact with biology, and all those other ones. So we are not discounting the role of genetics, but these social determinants play a key role. That is the conditions or environment where people are born, where they live, where they learn, where they work, where they play, where they worship, and age that affect them. I mean, it affects a wide range of health and functioning, as well as quality of life. So these are the 5 key elements: the neighborhood and built environment. As we know, there could be environmental factors, environmental exposures to toxins, to cancer-causing agents. There's the social and community context, economic stability. We know we can have financial toxicity from some of our therapies, education access and quality, as well as access to healthcare. So these all play together to constitute the social determinants of health. And it's important for us not to blame biology or genetics all of the time, but to pay attention to these social determinants. So what if, let's just imagine that we're able to somehow tackle some of these issues. What is the potential impact on the number of people dying in the United States from cancer? So here's the potential. Again, these are facts. We know that more than 600,000 individuals die of cancer each year in the United States. Some of the estimates, using very elegant models, suggest that nearly 134,000, or 22%, or 1 in 5, could have lived if they had quality health access to healthcare and to quality treatment. So these social determinants of health could have prevented 1 in 5 cancer deaths if we're able to somehow get a handle on some of these issues. Let me continue to emphasize the point about why this is important. So here's a study published almost 2 years ago in 2020, where these authors looked at persistent poverty and cancer mortality rates, analysis of county level poverty designations in the United States. look at the differences. Okay, so the black line are counties where you have persistent poverty, and the open lines are the ones where you have non-persistent poverty counties. If you compare, you can see that mortality is higher in persistent poverty counties, and even in those that are currently experiencing poverty. So the implication of this is that research, interventions, and policies are needed to address multi-level determinants of cancer disparities in these persistent poverty counties, and they exist in the United States. So if we now begin to look at our catchment area, let's bring this home to nearer home. If we begin to look at our catchment area, here is the catchment area of the University of Chicago Cancer Center. Look at, these are the counties: Lake County, Illinois, Cook County, DuPage, Will County, and Lake County in Indiana. This is where most of our patients come from. 83% of our patients come from this region. This is a population of about 8 million. We place more than 60% of patients on our clinical trials. And here are the demographics, okay? Now let's now look at the demographics of our catchment area. So here is the demographic by race. You can see the areas where you have non-Hispanic Black, Hispanic, and the rest of the areas, the majority population are non-Hispanic White. Okay, so if you superimpose this map on this map and look at the median household income, you can see some striking observations. The lowest median household income, this region here that is near the University of Chicago Comprehensive Cancer Center, coincides with the area where you have the highest population, higher density of non-Hispanic Black. So right away, you can see that the zip code level begins to play a role. The geographic location where you live begins to play a role in potential outcome. Okay, first of all, it begins to play a role in socioeconomic group. You know, what is the socioeconomic group for that patient? And then if you then drill down further and ask the question regarding some measures, there's a measure that is called Hardship Index, okay? Look at the Hardship Index around the same type of area. The more it's blue, the more the Hardship Index. Look at the concentration of the Hardship Index. Again, it converges around the same area, suggesting that this geographic, your zip code, the racial, the race, all of this factor into determining the potential outcome from cancer. Now, let's now begin to drill down into the numbers with regards to mortality differences. Okay, let's look at Cook County. Breast cancer, the rate of death is almost twice, 31.6 per 100,000 in Black females in Cook County compared with the white females. Look at the rate of death from lung cancer, 50 versus 34. Prostate cancer, we already talked about, almost more than twice the rate of death. Colorectal cancer, almost twice. Cancer of the cervix is twice. Uterine cancer, 2 times. So twofold increase in the rate of death, of mortality from cancer within Cook County, if you look at these major cancer types. And this is not just Cook County. Look at Lake County, Indiana, some of similar trend, okay? Will County, prostate, you can see 34 versus 18. Lake County, Illinois, 55 versus 18. So this this is not just a Cook County problem. This mortality rates that are different based on race, goes beyond Cook County and actually affects some of the other counties in our state of Illinois. I want to show this slide just to show how, again, if we focus now on cancer of the cervix, remember cancer of the cervix is a preventable cancer. Preventable because there is very good screening, pap smear screening. There's also HPV vaccination that allows us to be able to screen, to be able to potentially prevent cancer of the cervix. So let's start from the lowest numbers. The Chicago Loop area, 2 per 100,000. You go a little bit north, you see 2.3 per 100,000. But let's go to North Lawndale area, predominantly Hispanic, 86% non-Hispanic Black in this region, 10% uninsured, 38% poverty, 14% unemployed, 9.1 per 100,000. Okay, more than 4 times what you see Chicago Loop. This is a distance of less than 30 miles. Let's move on to the east side, 13.3 per 100,000. Okay, so this is about 6 times now of what you see in Chicago Loop. 80% Hispanic, high on insurance, 19% poverty, 18% unemployed. But look at the highest, Washington Park. This is 8 times what you find in Chicago Loop. 95% Black, 11% uninsured, 41% poverty, and 27% unemployed. So these are the striking numbers within a geographic distance of less than 30 miles radius. Now let's put these numbers in the context of cancer of the cervix around the world. Let's compare, let me go back to this slide. Let's compare Washington Park, east side, with rates of cancer of the death from cancer of the cervix. Again, remember, this is a preventable cancer because pap smears are available and HPV vaccination could make a tremendous impact. Look at the colors, the color coding here again, where you have the highest rates in these regions in Africa, in South America, and some portions in some areas in Asia. These rates are about 17.5, okay? Look at the rates in Washington Park and East Side Chicago. It actually compares with some of the rates in these other countries, which in my view, it's really unacceptable. Let me quickly touch on participation in clinical trials. Clinical trials are studies that test new ways to prevent and treat cancer. Typically, it's based on new scientific knowledge, and many times it has the potential for cure or at least prolonged remission. So in the United States right now, the numbers are not too great. Less than 1 in 20 adults with cancer will enroll in clinical trials. And you can imagine of that small number, the majority of clinical trial participants are non-Hispanic whites. Let me illustrate with a case in point. Black individuals account for 20% of newly diagnosed multiple myeloma cases in the United States, but make up only 4.5% of patients enrolled on clinical trials in multiple myeloma. So the question that this raises is, would all the trial data to understand how best to treat multiple myeloma necessarily apply to Black patients? So this is kind of framing the magnitude of the problem. And again, just restating some of the contributing factors. Now I've made a longer list. Okay, lack of insurance, the long-standing economic segregation, transportation, environment, the neighborhoods, diversity of the workforce, which affects the trust that people may have in the medical in the medical profession, and even some bias by providers, whereby they tend to have bias against Black patients. And in fact, a recent study by one of our students showed that Black patients are more than twice as likely to have negative descriptors in their medical charts, where the provider is putting some negative comments in the charts of Black patients. They are twice as likely to have that compared with their white counterparts. So how do we begin to address this? Because I've shown you numbers that I think are not acceptable for us as a society. So when I came in about a year ago as director of the Comprehensive Cancer Center, we embarked on a strategic planning process that led us to identify strategic pillars. Our strategic plan was a vision for growth and impact. So we identified 8 pillars, 8 areas of key priorities that we want to focus on. Guess what is pillar number 1? Pillar number 1 is to lead efforts to reduce the burden of cancer locally and globally and address cancer health disparities. That is the leading strategic pillar that came out not just from me. This was a broad group of folks within UChicago across, from BSD to the physical sciences to social sciences. And one of the key initiatives is to establish a comprehensive cancer center social sciences collaborative. And the goal of this initiative is to catalyze interdisciplinary collaborations using different approaches across a range of social sciences, engaging this school of the social sciences division, the Crown, and Harris, and all the other schools within the UChicago community, with the goal ultimately to shape public policy. For example, how do we deal with the uninsured and underinsured populations, which is a major challenge at the present time. In addition, we wanted to establish a comprehensive cancer center data commons to allow us to be able to study this, the outcomes in more details, and also advance early detection, behavioral and intervention research within our community. So I'm going to now turn attention and speak to some of the work that the Cancer Center is doing with regards to community outreach and engagement. What are we doing within the framework, within our capacity as a cancer center in terms of reaching out to the engagement and trying to solve some of this problem? So we're fortunate to have leaders of our community outreach and engagement program, Drs. Karen Kim and Nida Lee, who really have done a phenomenal job in reaching out to the community, leading a program. And I'm going to talk about some of those programs. And the vision is to eliminate cancer disparities and achieve cancer health equity. So what are the components of this community outreach and engagement? They are stated here, and it starts with monitoring the catchment area cancer burden and collecting data on the socium, these social determinants of health. What are the catchment? I showed you a lot of data on what is the most frequent cancers, which ones are causing the most mortality. So really, we need to define our priorities based on those types of information. And this group is responsible or really focuses on getting that type of information. Promote education, cancer control and research, and also inform research that addresses disparities. For example, breast cancer or prostate cancer. Those are key areas of priority for the Cancer Center because those are disproportionately affecting members of our community. And then drive policy initiatives to promote sustainable change is also one of the goals. To implement this, we established an Office of Community Engagement and Cancer Health Equity that we fondly refer to as OSESHE. So this office actually drives a lot of these initiatives within the community. We have a community advisory board with membership of this board, as you can see here, from all 5 counties in our catchment area. We have several meetings. They help us in priority setting. We have bi-directional engagement, and then we have working groups also within this within this community advisory board. We give out some small grants to pair our investigators listed on this column, the first column here, with community organizations, as well as members of the community advisory board, in looking at different questions, so that we have community participation in defining our research questions and in moving forward. So here, just a listing of some examples. You can see breast cancer theme. You can see a theme on HPV, prostate and colorectal cancers, lung cancers, as well as AYA, survivorship, young adults who experience cancer. How do we help them navigate and live a healthy lifestyle following their treatment for cancers? So these are some of the things that our COE is doing. The COE is also engaged in trying to understand cancer screening, as well as modifiable risk of cancers. Look at, again, I showed a lot of data on mortality, death from cancer. This is data on screening. Look at Hispanic population. The rate of screening is only 48%. Okay, colorectal cancer screening for Hispanics above 50 years of age is only 48%, whereas national figure is around about 71%. Look at the rate of obesity in both Hispanic populations and Black populations, almost 40%. Look at the rate of healthcare coverage, where people do not have healthcare coverage, 22% in Hispanic, 12% in Blacks, and 5% in whites. So these are disparities that ultimately translate into poor outcome for cancer patients. So what are we doing? We're doing a lot of cancer education and research and outreach. Here's an example, a program called Lucero, Latinos United for Cancer Education, Research, and Outreach, where we have established a task force, a lot of events, culturally tailored webinars, education, for example, education about colorectal screening, about breast cancer screening, cervical cancer screening, all organized via our Office of Community Engagement, Community Outreach and Engagement. So prostate cancer disparities, we already talked about mortality, death from prostate cancer, how it's higher in Blacks compared with other populations. So what are we doing? We got a grant from the Illinois Comprehensive Prostate Cancer Outreach Program that allows us to increase prostate cancer screening, a lot of education on risk and prevention, shared decision-making, as well as imaging research, statewide partnerships with community-based organizations and federally qualified health centers in hotspot counties in order to enhance screening for prostate cancer. We are also working on cervical cancer. Again, look at the disparities in cervical cancer incidence. I think we talked about Washington Heights and all of these areas, but compared with Loop, you can see again that the incidence and mortality is a lot higher in these neighborhoods compared with others. So what are we doing? Partnership with Equal Hope Chicago. We also got a grant that allows community health worker training and evaluation, as well as partnership with the Illinois HPV Cancer Task Force, so that we can increase the rate of HPV vaccine uptake within our community. This is a program that is very exciting. This is a program that is led by Brenda Battle. This is the Southside Health Transformation Project. It's a community partnership to address significant disparities in healthcare on the South Side. It's a 5-year grant from the state of Illinois, not just to UChicago, but in partnership with several community-based partners. So it has these 4 critical elements. Number 1, to hire 90 additional primary care physicians and obstetricians within the South Side, serving about 400,000 people. 50 priority ability to refer to 50 specialists, and importantly, training of 250 community health workers and care coordinators. This is where the Cancer Center comes in. So we are partnering with Brenda Battle and her group to be able to enhance cancer screening through a healthy community model of care. So we are trying to leverage this program to enhance cancer screening so that potentially we can identify cancer at early stage before it has spread all over the body. So the other things we're doing is in public policy and advocacy in areas such as tobacco control. I've talked about HPV vaccination and reporting. How can we reduce behavioral risk factors such as smoking and physical activity? How do we enhance screening in vulnerable high-risk populations? And how do we make sure there's equity in cancer treatment and access to care? So we are engaged in advocacy, in partnership with other groups such as American Cancer Society, working with through the state legislature as well. And one example of success is a new law in 2020 that gives Illinois Medicaid recipients access to clinical trials. So this will allow more access, especially looking at our underserved populations, ability for them to gain access to our clinical trials. So I'm trying to wrap up now. So what is the new cancer hospital going to do with this? First of all, let me remind us that the UChicago Comprehensive Cancer Center is really at the forefront of comprehensive cancer care. There are only 2 NCI designated comprehensive cancer centers in Illinois, and we are one of them. And the goal of this new cancer hospital is really to enhance our ability to deliver care as well as have deep engagement within our community. Some of the things that I already talked about, such as screening and prevention services, will be enhanced. But the guiding principle, one major guiding principle for this new cancer hospital, which by the way will be delivered in 2026, is that it places the patient and family first, where they will have seamless experience, access to clinical trials, multidisciplinary approach, all the care fully personalized within one location. So patients are not traveling back and forth, and that is likely to further enhance access to care. This cancer hospital will be a destination center for cancer care. Again, because it's going to consider cultures and communities beyond our reach. It's going to celebrate our diversity and really provide added value for cancer patients, not only in our region, but nationally and also internationally. And then clinical research and innovation, which is our foundation. A lot of clinical trials, translation of what we've discovered in the labs to patients, to clinical trials, as well as to trials within the community, what we call community-based intervention research. So Our vision for the future, talking about the future, is really to become a model for the rest of the country on this whole question of eliminating healthcare disparities. So the good news, and I take this quote from our friend and colleague, Dr. Otis Brawley, who says that cancer injustice does not require a technological solution. He contends that cancer injustice is not a science problem. It's not a technology problem. It's not a genetics problem. It is a policy problem. So one of our major focus is to be able to conduct research, catalyze research through some of the initiatives that will allow us to be able to have impact on policy, on public policy. And when I say public policy, it could be even at institutional level, it could be city level, it could be county level, it could be state level, and it could be federal level. How do we identify utilizing for example, the social sciences collaborative that I talked about to generate the best possible research and data that would drive public policy? And a lot of other things. We continue to provide services, screening services, support research in the Latinx community, and implement, what we call dissemination with regards to education and implementation of our science in the community, and really focus on enhancing minority clinical trial participation. So I think this is my last slide. So I leave us with this question. What is our goal as a society? Are we looking for equality, or are we looking for equity? Are we looking for justice? So here is, I really like this figure from this children's book of the giving tree. So if you look at this tree, it's bent in one direction. So the guy on the left side, when the fruit falls, he's able to catch it right away. Whereas this person on the right side has, the fruit has more distance to travel. All the fruits are on the left side. They are really not on the right side. So this is inequality. So if you want to say, okay, let's provide equality. So if you give them ladders, tools to be able to get the fruit, look at where most of the fruits are. They're on the left side. So this guy is still able to get the fruit because the tree is bent towards him and all the fruits are on this side. So how about equity? How about we lift up this guy so that he can also be able to get some fruit, not as many, but at least some of them. So you raise the ladder, you provide more tools, you provide adequate tools. This could be education, this could be community outreach, this could be engaging them, this could be providing health literacy, it could be providing healthcare coverage. All of those things in the social determinants of health that we talked about in order to provide equity. That is one of the things I consider this as our short-term objective. The long-term objective really is justice. How do we bring this tree back so everyone has equal access to the fruit on this tree? How do we correct this tree from being bent and make it straight so there's justice, equal access? This really is the ultimate goal. And I have this dream that, hopefully 20, hopefully less than that, maybe 15, 20 years from now, the dream is going to be that we have healthcare, cancer healthcare justice, where all people, regardless of race, gender, ethnicity, sexual orientation, education, geographic location, whether you are rural or you live in the city, will have equal access to cancer healthcare, high quality cancer healthcare. That's my dream. That is our vision for the University of Chicago Comprehensive Cancer Center. And with that, I will stop and invite Dr. Polite back, and I will take questions.
Dr. Odunsi, thank you so much for such a comprehensive review of what I think most of us would agree is a national and international tragedy. But most importantly, thank you for providing, I think, a vision of how we get to a better future and where we as the University of Chicago and the University of Chicago Comprehensive Cancer Center, the obligation that we have to achieve that. I'll take the first question from, it's a classic University of Chicago, beautiful question that I think, very much will allow you to sort of sum up what you said. And this is from David Bickham. Said, if you could cure cancer, what proportion of this country's and the world's population would realistically have access to it?
Yeah, that's a great University of Chicago question. If you think about one of my last slides regarding how we have inequality, so talking about within the United States, we know there's inequality, but it becomes even more magnified if you think about the world population. I showed you that world map where you have those countries where the color was dark, whether it's in South America or Asia or Africa. So right now, if we could cure cancer, access for those countries, I think, will remain limited unless we do something on a global scale whereby we enhance access to the best, these curative therapies in those countries. And there's a lot of effort going on actually at the University of Chicago, led by Fumi Olopade and others, Habib Hassan and others, looking at how do we help those other countries. Within the United States, I think if we have a cure, my suspicion is that we will see access increase because it becomes a national question. I think this would be a question that potentially Congress will address, to say we need to make cure available for everyone, regardless of their of the population group that they belong to. So I think access, I couldn't give a number, but I think it's going to be very high because it becomes a political issue, which potentially will be addressed by Congress and maybe even the Supreme Court.
Thank you. The next couple of questions center around what we know is a broken and dysfunctional public health and insurance system. Mara Deaton, speaks to the issue of what has been coined in the literature as financial toxicity. So the fact that medical bankruptcy from out-of-pocket costs and all these wonderful new therapies are very expensive, and how patients can be protected in this. And Kathy Schreiner brings up an article that she read early in the pandemic about a Black man in the South Chicago area who was not taken to the nearest hospital to a hospital further from his home with lower quality services, and he died. So I think those get to the bigger question of, when you are University of Chicago, sitting where we are in an urban center on the South Side, and you are operating with insurance systems that are not necessarily in the best interest of patients all the time, and a public health infrastructure that has been underfunded. What are the challenges that presents to somebody like you as the Cancer Center Director, and sort of the opportunities and obligations that you have to work within that type of system?
Yeah, that's a great question. And that's something that I think about all the time, because here we are, University of Chicago Comprehensive Cancer Center, one of the best places in the world to be treated for cancer. And yet you have, potentially you have patients who are uninsured or underinsured. So, so the first thing is to make sure we leverage all of the possible resources through our social care network our social services to make sure that we can accommodate all patients. The ideal state is that no patient should be turned down for their cancer care. So, we work hard to try and navigate that by working with the insurance companies. Some patients come in, they are out of network. We try and get the resolution to those things by working with the insurance companies. But many times it's challenging, and that's the reality. So again, this is an area where we need to focus on in terms of further defining the problem and conducting the most appropriate research on how do we as a society address this gap in our health system. And ultimately, I think it's going to require a policy change. Just like Dr. Otis Brawley said, this is not science, this is not technology, this is a matter of policy. But to drive policy, you need to do the most appropriate form of research to convince all stakeholders, policymakers, that this is going to be the way to go.
Thank you for that. So I want to ask you a question. I think that was beautifully embedded in your talk, but one of the debates that always goes on is when we think about something like race as a social versus a biological construct, and how somebody like you who's embedded in the research has thought about this very comprehensively. How do you answer that? How do you answer that question that often gets asked?
Yeah, I think again that's a great question, and we go back and forth about race, and as you know, there are, you can test your genetic ancestry, for example, to determine what is your ancestry. However, that does not fully define race. Race is both biological, but more so social construct, because it's all of those, it encompasses, where you live, your environment, and even to the extent that it even goes up to the level of your socio-economic status. So race is not fully a biological construct, number one, and it's more of a social construct. And even if you look at biology, there is so much admixture with regards to race that simply classifying, based on potential racial background needs also to be in the context of the social circumstances of that individual.
Thank you. Yeah, wonderful answer. I'm gonna take a question here from Hillary Silver. The question is, are there programs to get survivors of cancer, communicating about things like screening, et cetera? And then I would sort of broaden it by saying, obviously one of our greatest assets and resources is, the diverse group of patients that we've treated over the years, who, I think had a chance to experience the care they can get at the University of Chicago and have learned a lot about cancer. How do we think about using, those who are interested and willing and want to volunteer, to be ambassadors out in the community for the importance of screening, et cetera? And how do we think about that as a resource?
Yeah, that's a great that's a great point, and this is something that we have started thinking about. We already have some of our cancer survivors who are serving as ambassadors for the cancer center in the community. Some of them serve on our community advisory board. Some of them serve as volunteers, and they serve as ambassadors in the community. But we think we can still do a better job of fully leveraging these volunteers because they are willing, they are able to spread the news regarding cancer screening. Again, it breaks my heart when I see patients who have stage 4 cancer of the cervix, because this is totally preventable. If that patient had just gone for that pap smear last year, maybe we'll be talking about stage 1 and not stage 4. Or maybe we'll even be talking about pre-cancer and not cancer at all in the first place. So just getting the word out about screening, about healthy lifestyle, physical activity, diet and nutrition, the right diet and nutrition. I think, we still can do a better job, but we already have a cadre of volunteers who are helping us in some of those different capacities. I talked about that Office of Community Outreach and Engagement, OSESHE. Many of the people that help us from that office are actually volunteers, and they are very, very effective.
Thank you so much for that. And again, thank you for, I think, a wonderful presentation, very enlightening, and, for all that you've done, in what seems like a very short time here, which it is in a year, but just, I think, tremendous work, and looking forward to, where we go on this journey together. With that, please accept everyone's virtual applause for your work today. And that brings us to the conclusion. I want to turn it back over to Andrea for some closing remarks. And thank you all for your attention this evening.
Well, thank you, Dr. Odunsi, for sharing your work with us. So important. And thank you, Dr. Polite, for being here to extend the conversation so thoughtfully. Thank you again, and we'll see you soon.